Health from one of the masters. So, Jay, I'll turn it over to you.
All right, master class. Hey, everybody. Um, I can't see the screen. We have how many people we have out there? About you said 16, Brian. Yeah. So congratulations on almost matching. I know it's a stressful time for you all, and thanks for giving this course and this topic, and of course myself some time to connect. Um, we're gonna today get this right, and that's where I came from. And before I go that, we're gonna talk a little bit about climate change and health. I'm not gonna do the 101. You've had that. I'm gonna try to give you a sense of where medical education is going. What are the some of the grand themes? How we're gonna tackle this problem, and then opportunities for you all. Um, I'm gonna go. We'll go robustly through this, so we have some time to talk because I really want to hear from you on your thoughts and your reflections, and I think that's probably the best way to kind of flesh out some of the issues. So I'll give you a little bit of sense of where I came from, just to give you another example of trajectories really come from in all different shapes and sizes. And so, with that said, let me show you exactly where I came from. I grew up in upstate New York, not the New York City part, but really the Vermont, Canada part. This is the Adirondack Mountains. This is Lake George. I grew up about 5 minutes from here. And it really, you don't think of it at the time because you're a kid and then you're a punk teenager. But you really, where you come from, I think really informs a lot of how you approach the world. And so I sort of found myself gravitating back to environmentalism. The Adirondack Park is a protected part of New York and was actually the progenitor, I guess, if from Governor, then President Teddy Roosevelt for the National Park Service. So again, it sort of came back to me much later, and actually, really here, this is where I trained. This is Bellevue Hospital in New York City, and so I was there and did an emergency medicine residency, and then started a wilderness and environmental medicine program just up the river at Cornell's Med School, which is in New York City and very much informed by we had just experienced 9/11, the terrorist attacks. I was a resident then. And this was also the ascendancy of global health in academia. Um, right around this time, this is about 04, 05, when I started there. And my chair at the time was like, yeah, go ahead and start a wilderness medicine program. And as I thought about it, I was like, well, how can this be germane to New York City, and then I thought, okay, we have a real opportunity to overlap with disaster response and global health. And really, it was around this time we began to see the politicization of climate and health. And I remember thinking, listen, policy, fair to debate that, how we spend our money as a society. We really shouldn't denigrate the science because then we all just become idiots, which seemed like a very quaint thing to think back then, considering where we are with science in the United States today. Um, but that was how I sort of got my first start in in climate and health, and it really derived from wilderness medicine, which is kind of different. It gave me a different perspective as a clinical doc in wilderness medicine. I wasn't a public health official, so I was a little bit different in that regard. Um, I met my wife and we had a baby in New York City. And immediately I thought, well, it's time to leave New York City. And we moved to the University of Colorado, where I have been since then. And took the wilderness medicine program, but really took also this incubation of a climate and health program. Today, I want to talk a little bit about climate and health foundations. You've had a lot of that. So it's going to be my take on it. Borrow my language, borrow everyone's language around this because this is going to really help you create your own narratives. And guys, the world needs you. Okay. So take your narratives, go forth and be an impact change. You've got a big job ahead of you in your residency. That's really important. That will underlie that's your superpower, the clinicians that you become. But it's going to be very important after that to think about, okay, what is your larger impact on the world? And hopefully this will be a part of it. So we'll talk about climate health foundations, talk about climate medicine. You might be saying, is that a thing? And the answer is it might be. We sort of invented it, but we're hoping it's a thing. We'll talk about what that means. Talk about our diploma program, and then some larger issues around and opportunities around healthcare system decarbonization and resiliency. And then finally, a little bit of like, all right, where are we now? What's going to happen to the world? So let's dive in. This is how I got started. This was my mentor, who was one of the grandfathers of wilderness medicine, Paul Auerbach at Stanford in '08, wrote an op-ed in JAMA, which is, it still holds up. So if you're really interested in maybe sort of how this evolved, it's, very discoverable. It's a two-pager, and it was really like why physicians should care. So really, very cool. And it sort of got me thinking about this more. And essentially, the essence of it was we need to use our formidable powers, the powers of our white coat, the patient doctor-patient relationship, and use that power of science communication to change the climate dialogue, get away from polar bears on icebergs, and really make it about kids with inhalers. So this is one of the grand changes of how we think about climate change, and I'm sure you're very familiar with this at this point. This is one of the big take-home slides. It's actually a bigger message a few years ago when this was sort of an aha moment, and now you all are probably saying, "Yeah, yes, of course, dummy, keep going. We got all this." Um, and get away from altruisms, save the whales, love Mother Earth, abstractions, 400 parts per million of carbon dioxide at Mauna Loa measured last week, right? What does that mean? And I think public health has generally failed historically in the last few decades of getting the message out there. I love whales. I love my mom, but really, it's important for us to hit a more active part of our limbic system for change, and really to begin to think about our parents' risk of chronic lung disease, our kids' risk of being attached to an inhaler in the world that we're slowly creating. Think about how we communicate this. Um, for years, we basically stopped at number four, and this comes from Ed Maybach out of the George Mason Center for Climate Change Communication. Hopefully, you're familiar with his work. He's a communication PhD. He talks a lot about climate and health. He's not a care provider, which is great because we need communication specialists to tell us what works and what doesn't. And what doesn't work is stopping at it's bad and not including hope, which is where we did for years. Let me just kind of go through this with you. I tweeted this out, by the way. I called it Maybach's Pentad. I thought that this was years ago. I thought it would go viral. It didn't. It was four people retweeted it. And now no one's on Twitter anymore. But anyway, here we go. It's real. It's us. Experts agree. It's bad. And there's hope. Let's break it down. It's real. Climate change is real. The effects are real. We can measure them. The data is robust. Not much debate. It's us. This is human cause. This is not a cyclical epic in the natural history of the earth. Experts agree. Pick your experts. No one is seriously debating this in science anymore. We know that there's been false equivalency in different media channels where a scientist from a austere institute comes on and says, we don't really know. We do know, actually. No one's debating this anymore. It's bad. There are consequences to our environment, and there are derivative consequences to the Homo sapiens living in that environment. Aha, we have to end on this. There's hope. Good things are happening. Technologies are proliferating. There are economic value to do them. Communities are more robust. There are chances to reimagine healthcare delivery with these changes. So we have to remember to end on an upswing because no one wants to hear doom and gloom. It just doesn't work from a communication perspective. You're familiar with this. I threw this in here as I think about, where do I go for the repository of science? There's so much out there. The IPC is great. Um, I'm sure Brian showed you this. This is the Intergovernmental Panel on Climate Change. It's where all the best science gets collected. It's a quadrennial report. But the sixth one dropped at different stages 2, 3 years ago. Um, and it's where all the best data lives, and you can read executive, 5-page summary or the 400 or maybe 1,000-page report. Um, but when I give interviews, people love to say, Lemry, what really bothers you the most? What are you most scared about? Or what's the top 5 things about climate change? It's a complicated topic, as you know. This is the CDC slide. I think there's many derivatives, many versions. This one's old, but it still holds up. Now, what is it? The inner circle are those drivers. Now, you could say there maybe should be 2 of them. So, increased carbon dioxide levels leads to rising temperatures, but we see that more extreme weather, energized weather, rising sea levels, right? The cryosphere is melting. Very simple science. You melt an ice cube, the meniscus of the water in the test tube goes up, right? Very simple. Um, and then the circle is the Earth science changes that happen, and then the square is how it impacts humans. So I throw this up there because again, it helps us sort of get the full picture, quick, intuitive, easy. And there's many versions of this, but this is just the one I have used, and I'm a creature of habit. So I call it a disease. And whether that's precise or not, I don't think it matters because I'm not speaking, to National Academy peers. I'm speaking to the public when I say this. And so we have to think about how we communicate the risk. So it's a disease. Well, of what? It's a disease of infections. Yes. Again, I'm going to go fast because you know all this. A vector-borne disease, it changes in latitude and altitude, right? It's expanding to historically naive populations. Degraded air quality, drought, and extreme weather, precipitation downpours, food insecurity, waterborne illness. With those downpours comes flooding, and flooding leads to diarrhea, right? We mix where we grow our food, where we go to the bathroom, and where we live. When that gets mixed, um, diarrheal outbreaks. And make no mistake, diarrhea is just not an inconvenience. It's the leading cause of death for kids under 5 worldwide. Heat stress, it's hot. We know that there are vulnerable people out there. And we don't always know the attribution. Your elder, Stefan Wheat, wrote very elegantly about the need for attribution. Stefan was a former graduate of Arizona and one of our fellows, and he wrote elegantly about the need for attribution science. People people come into the emergency room and they come in with chest pain, shortness of breath, diabetic complication, COPD. They don't come in with hottest day of the year, which exacerbated those chronic diseases, right? So that attribution is very difficult. We're just not set up to get it. Mental illness, so it could be climate dysphoria or this feeling that things are changing, and that's an impact for anyone who's, I can't see you right now, but if I said raise your hand if you know anyone who's been impacted by climate change, um, everyone's going to raise their hand. And if you don't, we're going to talk a little bit more about it because, as we sort of explain, has you've ever seen anyone lose their home or had to move? Chances are you do know somebody, and that's a big thing, displacement, and then the very trauma. Think about the Paradise fires we just saw last 2 months ago. So when we contextualize all this, at least in the US, right, we think about extreme tropical cyclones ravaging the Gulf communities, and then extreme downpours causing neighborhoods to be unlivable or have to move in New Orleans or Houston. And then degraded air quality and outright destruction of neighborhoods and villages in California. It's a disease of vulnerability and disasters. And that's why I've landed on this for years. It's a little bit EM focused, emergency medicine focused, but really that's what this is. It's the most vulnerable will be pummeled, and it comes in profound, everything's fine, 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 maybe a little hot, and then boom, there's a disaster, right? So that's what it is. Um, that's how I used to finish my talk. Thank you very much. See you later. But then I've moved on and I really have gone deeper in my understanding. And I think all of us in this field sort of have. And that it's really more than that. It's a disease of ineffective communication, systems failures, and a lack of leadership. I just sit with that for a second. All right. So what next? Well, I'm still trying to find a good leadership quote or a lack of leadership quote. I borrowed this from Truman. The bottom line is when there is no leadership, nothing happens. Society stands still. So we've got this imperative to lead. We have got to rally around this and use our formidable powers to move forward. And that's kind of where we landed on this. So we sort of said, okay, as clinical medicine, care providers, doctors and nurses, what do we call this? Well, it's maybe a beat different than public health. Um, so let's call it climate medicine because it's really the how does healthcare interface with climate change regarding health and wellness of our communities? So we're seeing more and more people within medicine gain momentum. And this is irrespective of politics. This is the Medical Society Consortium on Climate and Health. It's out of Washington, D.C. And you can see here major medical societies. In fact, the majority of clinicians are represented by these societies. Doesn't mean everyone buys into it fully, but they all have a seat at the table. And it's been a wonderful way to kind of create a commons for conversation. So we're seeing momentum and it's great. When we think about, okay, well, how does the interface look like? What does it look like? This is a kind of a grand inventory we wrote up for Health Affairs a few years ago. Let's just kind of go through it. There's sort of three big themes on campus, so the academic medical systems and med ed. Um, Dedicated climate and health curricula. Bravo, that's where you're sitting today. Um, um, uh, Master's and PhD training programs, lecture series, and grand round speakers to get the word out. All those things that academic campuses do. Interdisciplinary research. We've done a lot of work with environmental scientists, for instance, thinking about ICU admissions during wildfire seasons or wildfire flares, community outreach advocacy, integration with global health equity, social justice, diversity, inclusion initiatives, really important to be synergistic with ongoing efforts because there's so much overlap. Um, in clinical practice, so our practicing clinicians thinking about health society engagement. How do they relate to one another out in practice? And it's through, they're all obstetricians or they're plastic surgeons or internists, and they all, go to their annual meetings. So thinking about their health society, thinking about CME lecture series. How do we, the rest of your life, you'll need to do continuing medical education to stay current. It's also a requirement for where you practice and we can influence that. Formal policy statements regarding, how does pediatrics approach this, right? How does allergy immunology approach this? Dedicated space and maybe section editors within peer-reviewed journals. Um, Social media, every group has a social media channel. So the social media presence, thinking about greening infrastructure, best practices to disseminate, whether you have a small clinic, an operating room, emergency department, hospital, or even healthcare system. And then larger things around sustainability and policy. So greening, climate, smart health care initiatives. And we're going to talk a little bit more about this. Not just the right thing to do, it's also, if done right, makes huge economic sense and sets you up for the future very well. Um, and so thinking about that, thinking about adding renewables to your energy mix, having sustainability champions, people that are change agents that are capable and knowledgeable and credible to do this work. Um, and you can't do it without measuring. So how do we pull hospital metrics? What do those best practices look like? And then other things like, are there low-hanging fruit, carbon offset travel programs, divestment of financial portfolios from, historic oil and gas. Those are big messages. So who's going to lead on all this? Are any of us trained to do this? Well, that was the question we had, and we said, all right, let's do some training. Let's clone people with these skill sets and have them go forth and be ambassadors. So we started a GME, Graduate Medical Education Fellowship. This was done after residency. And I incubated it in my program, which was emergency medicine. We had one a year, and they were clinical docs in our emergency department. And we sort of got them up and running um, with very basic fluencies. You can see here, what do they need to know? None of this is, I imagine, shocking, right? You've got to know how climate and health work together and what are those impacts. You have to understand basic public health concepts of mitigation and adaptation. Um, we want them to understand programmatic development. What do you do with these skills? Well, here's how you go out and be a change agent. So change management. And then, of course, one of the big skill sets is being able to communicate, not just on the podium, but in all form, right? The elevator pitch, the talking to your CEO, talking to students, talking to your family members and lay people, writing PowerPoints, tweets, op-eds, all those things. Um, but since then, we knew that we were like we need more. This is a precondition. It's not enough. We've got to create that credibility, knowledge, and effectiveness that it really is commensurate with leadership. So. And why is that? Because we want our docs to go out and push the health agenda and to be able to spar with CEOs, community leaders, and policymakers. Being able to sit there and explain to them why it's important and also have enough fluency that when someone pushes back and says the Texas power grid failed a few years ago because pigeons were flying into the wind farms, to have enough knowledge to say, respectfully, that is just not true. And to be able to be credible, not an expert, but enough knowledge. We're health experts. Um, and we know we have not gotten this message across well, right? How do you explain heat and geopolitical instability, right? I explain it in one word, Syria, right? There's a complicated story there, right? So how do we talk about force multipliers in geopolitics, loss of biodiversity and pandemics, extreme weather and food insecurity, right? These are complicated things that no physician who's learned how to take care of patients can really, they're very smart. They can probably figure it out, but they're just not trained in it. And we just needed to make sure that's the case and be able to articulately state time and time again, um, those with resources will have resources to mitigate this. The poor and sick are going to get pummeled and really hammer home that this is a disease of vulnerability. There's real consequences and it's not evenly spread. Um, so again, what the core competencies, if you will, a trusted resource can explain things lucidly, incredibly, and convincingly. Currently, there's us. We actually went out and started. There was a small university in Boston that needed our help. They're not very good at doing things, and so we said we'll come help you. I'm just teasing. It was Caleb Dresser who was our one of our first fellows. We helped start that program, and he has a program at many of the Harvard institutions. So it's us and Harvard, and that's kind of it. Um, but here's the exciting thing: as I'm talking to you as pluripotent. Um, Care providers yet to match. Probably too late to change your match. That's okay because you don't have to, because all of you can do these fellowships if you're interested. And you've got time to think about it, obviously, at the end of your residencies. But here's what I think is very exciting. This is an all hands on deck crisis. We need everyone to participate. What started off as EM, now we have 5 fellows a year. We have changed our model. COVID really helped with that. Obviously, changed so much about medical education, where our fellows are throughout the US. They have their own jobs and they give us time. They're about half-time jobs where we're able to pull in neurosurgery, palliative, peds, allergy, immunology, radiology, and ophtho, right? Who would do these? And the answer is everyone's interested. Neurosurgeons and neurologists are interested in plant-based diets and the elimination of the land use and water use of cattle, which of meat base, which contributes so much to climate change. Radiologists are actually well poised and experts at hospital operations, so they're decarbonization mavens because of where they how they interact. Um, and here you can see we have our fellows have each have a nonprofit and put an asterisk by this and a federal partner. So we had our 5 of them had different partners. The federal partnerships, because of what's happening in Washington and just a general demise of anything climate and health, we're changing that this summer at the academic year. So our federal partnerships, we're going to push a pause, and then we just didn't think it was a good learning experience for our fellows. But luckily, we've got so many other partners that this pivot will be, it's one of those things where if in a perfect world that wouldn't have happened, but it's an opportunity. Um, and here's us just getting it out there, getting to places where the conversations are happening. These are some screenshots from the COP conferences, the UNFCCC UN Foundational. Someone can help me. Um, Foundation Framework Convention for Climate Change, which is the kind of the grand rally for climate, all things climate and health is increasingly taking a bigger role. So, um, then I get a call from a dermatologist in Tampa. She says, I have three kids. I have a booming practice. I'm 10 years out. I can't do your fellowship. What do you have for us? And it was a really compelling conversation because I was like, yeah, we need to do more. And so we thought, how can we pull in all of healthcare into doing this? And we came up with this concept of a diploma in climate medicine, modeling it after some other diplomas that are out there, a diploma of tropical medicine and hygiene. For those in the wilderness world, diploma of mountain medicine. But these are big credentials. People often put these letters behind their names. So J. Lemry, FACEP, right? Emergency physician, DCM, Diploma in Climate Medicine, which I'm not, by the way, because I don't have time to take this to take this course that we started. Um, but that would be the credential that we would want people to wear as a sign of credibility and knowledge. And so, these are heavyweights. This is a 300-hour monster. We said if we're going to do it, let's do it big, and it's open to all practitioners. And so, here are the basic um, courses that we have, and we break them up into 5 courses, 60 hours. A lot of it's hybrid, right? So we need people in person for about 3 or 4 days, including travel. So trying to again think about busy clinicians. Um, but we talk about foundations, healthcare sustainability, disasters, energy policy, and healthy communities, and then grand systems and policy. And people say, well, where's climate justice in here? Where's communication? Those are themes that are ribbons that run throughout all 5 of these courses. Let me just break them down a little bit. So Climate and Health Foundations, here we start in Boulder, or sorry, we start in Denver, and we go up to NCAR, National Center for Atmospheric Research in Boulder, and do climate modeling. Now, why would a doctor ever need to do climate modeling? And the answer is you're absolutely right. No doctors needs to or ever will do climate modeling, but it's an incredible bonding exercise to understand where that science comes from and how that climate modeling goes into climate predictions and how it's verified and validated and how those climate impacts now trickle down into health impacts. Something very simple as heat, degraded air quality, asthma, COPD, right? Um, and so for a clinician to be able to stand and say, I have been to NCAR, I have talked to these people, I have seen climate modeling. These people are very smart, and be able to just talk about that chain of science is really important. And then in the end, we head up to Rocky Mountain National Park and sort of pull it all together for our first iteration. Second is healthcare system sustainability and resiliency. We go to Clean Med, which is the healthcare industries decarbonization sustainability conference. It's interesting because this is a healthcare conference where most of the people there are not actually care providers. They're healthcare system um, operators. And so thinking about scope one, scope two, scope three, which hopefully you know about, that's just how we categorize the very big uses of carbon. Scope one, you know, what's powering the lights on? Scope two is, what when patients and doctors and nurses drive to the hospital, what carbon are they using? Scope three is, my intravenous catheter or this vial of medicine. What's the carbon impact of each of those little things? Very difficult to measure, but that's how we sort of and think about it. Um, Brian, this is where I'm going next week. I'm going to Disaster City. It's at Texas A&M. You can see here, it's literally a train wreck. And this is where we do disaster curriculum and the anatomy of a disaster response, because so much of this will not be not is gonna come in the form of climate change. Oh no, it's gonna come in from like, well, the city's underwater, or um, there's a heat wave that is a heat dome that, we're 40 degrees hotter than we ever thought we were, and the elderly are coming in with end organ failure, things like that, just overwhelming healthcare systems. How do we even begin to process that and understand it? Course four, looking at fracking sites, looking at exemplar cities, who's doing it well, and, creating green space, and what are the impacts and how do they measure it? And then other things like rare earth mineral extraction, and then renewable energy places. And course five, thinking about systems and policy and how things actually get done or don't get done in our nation. No one has been trained for any of this, and this is really where it comes from. Everyone is going to need a climate plan, no matter what endeavor we're running. And if they don't, they will soon, right? It's just a worsening crisis. And our job is to make sure that the health impacts are paramount, are at the forefront of these solutions and policy. And so we need to be able to communicate with all of these stakeholders and policymakers. All right, so wrapping up, I want to kind of just talk to you about uh, sustainability and resiliency. This is sort of that course two. So this is a trend that I think will be having greater resonance for you and greater opportunity in healthcare. Um, the national academies, who are exemplars of our field, and leaning in hard into this, are having action collaborative on decarbonizing the U.S. healthcare sector. Why? Well, remember that first rule, right? The very first rule of medicine, right? Do no harm. And so we are 8.5% of the United States carbon footprint is healthcare, right? And if you don't believe me, just go look in any trash can in any clinical setting. You're like, yeah, there's a lot of waste here. So how do we begin to approach that? We are collecting big green data, energy use profiles, patient vulnerabilities, expenditures, health outcomes, right? Lancet's doing a great job. They have an annual survey. They've been doing this for years. So we have data coming in. There are nonprofits supporting healthcare systems and practice green health affiliated with Healthcare Without Harm. Numerous cross-sector metrics. And how do we process this? How do we digest these metrics, um, and come up with a plan? And it has to be a patient-centric plan, right? That's what we do. That's what healthcare systems do. We've been living in the age of big data now for 20, 25 years. Think Facebook, but we haven't been able to really effectively process it until recently with the advancements and the scalability and the accessibility of artificial intelligence. So um, think about this, where a healthcare CFO, they make the big financial decisions, cannot go out and buy solar panels, pick something easy, because they don't know. And even if they have the best practice playbook, they don't know that it's going to make a difference in their bottom line, in their they make a difference in carbon output. That's probably pretty easy, but their bottom line or patient outcomes, how do they even begin to measure that? And the data that they have, it's extremely expensive, has been, to process that their own idiosyncratic data, if in fact they even collect it. Um, what AI now allows us to do is to separate that signal from noise and think about, okay, turning the knobs over here, um, regarding decarbonization. How does that impact carbon output, patient outcomes, and the bottom line? And so I think these are going to be increasingly valuable, even in the current political climate, um, as these technologies become easier and easier and cheaper to use for healthcare systems to have their own bespoke data sets to say, here's the plan, here's how you do it, and you're going to save money in your first quarter. Those are all motivating factors. But then the question is like, okay, that's great, but we know people, lots of things in healthcare don't move until there's a mandate for hand washing or central line infections or patient safety and falls, right? So what's the situation with there? Well, there was a lot of movement. Um, we had a lot of thought leaders talking about this, including the president and CEO of the Joint Commission. the Secretary of HHS, of course, in the Biden administration, all were floating these ideas and kind of pushing this agenda. Um, Ken Kaiser and Carrie Nadeau wrote a great piece, which sort of said the federal government, right, because we don't have a single federal healthcare system, is extremely well positioned to use its leverage to to force hospitals to move or to incentivize, however subtly. Um, well, clearly that's different now, right? We're not going to see any movement on the federal government pushing this agenda. And in fact, what we had thought maybe would be a flat line now looks to be actively aggressive moves to undo and even incentivize carbon-based energy sources. So, um, does that mean these sticks don't exist? Not really. We know that the incentives will, from the IRA, the federal government incentive cease, but states and local governments and lots of healthcare systems are seeing the future. They know this is the right thing to do for their patients. There's brand recognition. There's cost savings to be had, and so and there's a lot of reports that suggest that patient systems that have moved on this certainly at first will have very low hanging fruit to have cost savings. So, all right, so taking stock in where we are now, the despite all these changes in Washington, the inexorable march of climate change continues, and its impacts continue, and they are continue to accelerate and compound. So we know that January was the hottest month on record. Hottest January on record, and 20 this year already, we have lost a major part of a major American city in the LA area in Palisades. We know that states will increasingly be picking up the void. And so this, if you're a healthcare system, you have Fed regulation, you have state regulation. So it's not um, a on-off switch, if you will, at the feds. There's still lots of things. And then, of course, any healthcare system has to plan beyond 4-year election cycles, right? So there's just a lot of uncertainty and a lot of strategic sense into be paying attention to this. And I think it's just important because it feels like everything's being undone. Um, and then, and here's the old curve, healing curve, which just tells us that we'll be at this for a while. It's not going anywhere, and we know what pain and suffering looks like and the underlying causes for it. So, think we have time to discuss. I'm going to stop sharing, and thanks for having me.
Awesome. Great, great chat. I mean, Jay got me interested in this too. So, I mean, I think from that conversation, you pushed me to get involved with the consortium, and then that led to, the next thing and sustainability committee we created at our hospital. It's like you just one little thing at a time, right? It's not that you're going to learn all this or do all this tomorrow. You choose one thing and you start to move forward with that. You pick up a little bit, just like we learned medicine. You didn't learn it in one day. You're not going to learn your residency in one day. So, I think great perspectives. Any questions? What questions you guys have for Jay?
I have a question. Um, how do you frame conversations with people that say they don't believe in climate change? Like half of my family is like, no, it's not real. And how do you approach that, I guess?
Yeah, great. It's a great question. And the thing I think is really important is it's hard. Um, the first thing is know your expertise. Now, I just explained that we have to be able to flex and discuss things, but when you're in a contested conversation, people always say, well, what about China? And they're not doing anything. And they're building coal plants. And why should the US do anything? And I sort of pull back and say, listen, I'm not an expert in geopolitical economy, but I am a health expert. And so own your expertise. That is your Alamo, right? That is, you will defend that. And say, but here's what I do know is if we keep at this, we're going to be seeing more and more people coming in And you can play any, I do this with my patients with COVID vaccines. It's like, do you trust me? Yeah, sure, doc. All right. I'm ordering all sorts of things that if I'm not doing it right could shut down your kidneys, right? Could make you blind, could do all sorts of toxic effects. And you're not asking me a single question. You just trust me, right? So that's like, trust me on this one too, because this is it's a big deal. Um, and we're seeing it. I'm seeing patients. And as a physician, our job is to understand the drivers of disease, right? It's the same thing as seatbelts, smoking, you know, um, fatty diets and exercise, things like that, even gun violence, right? So we have a mandate to talk about these things. So try and, if you can do that, there are documents out there that explain to you how to communicate this. And it's, find common ground, connect on things. This is your family, so assuming you have all that. And the last thing I'll say is Ed Maybach, a communication specialist, describes six Americas. And, at one end is I'll just vote for me. I'm over here, right? I'm the guy who's like trying to do things about this. And then you have varying degrees of skepticism and engagement. At the very end, it's just like, nope, drill, baby, drill. This is not a thing. This is just a liberal plot to undermine, to control the government and, our brainwaves. You leave them behind. You don't engage with them. They're a waste of time. They're an energy sink. There are not many of them anyway. I think Ed describes 6 to 8% of the population, certainly enough, but he's like, they're just a waste of your time because there will be nothing that you gain. No one gains from that. But it's the other ones. It's maybe if they're number six, then there's four and five who are skeptical, um, but are willing to kind of engage. And so then it's just using all your skill sets as a clinician. But I think own that expertise, right? When we wear that white coat, we still hold the public trust. When I say you have to have surgery, you've got to take this medicine, right? Universally, everyone says, okay, doc, because they trust us, right? And so I think that is our superpower, which is very different than maybe Holly, the med student, talking to somebody versus Holly, the doctor.
Thank you.
Let's see. Ben has a question in the chat. What kind of patient care or systems level change have you seen graduates of the Climate and Health Science Fellowship enact?
Great question. So we're training pluripotent change agents, so we don't really care what they do. They're not necessarily designed to be professors, although some have gone into academia. Stefan Wheat was one of them. Started a program with Jeremy Hess up at UW. Some have gone into academia, others have gone into global health. Cecilia Sorensen at Columbia has really leaned into this Columbia School of Public Health and the Global Consortium on Climate Change and Health. Others have leaned into healthcare system decarbonization. Emily Spiroli in Southern California has done that. Um, we've had our graduates go and really lean into their local nonprofits. There's a woman in Chicago who's now promoting green space and talking a lot about that. We've had some people do public health research and initiatives for vulnerable populations in Alaska. Another guy jumped in with a political campaign in Pennsylvania, which, if you know anything about politics, that's a state where we see a lot of back and forth, right? Red state, blue state, one of the swing states. Um, and so he's done that. So really, those are the changes that we want and that we expect. But again, we're not asking people to. I guess I'll just say one more thing, but we're not asking them to necessarily have a particular flavor. We just want them to go forth and change. One of our grads also just helped publish the guidelines for the American Academy, whatever the neurology is. I think it's American Academy of Neurology. Um, their guidelines, and a lot of it obviously was cardiovascular risk and plant-based diets as a rationale.
I'm curious, especially with like the recent kind of FEMA cuts, and right, like are kind of increasingly severe weather events, if you see anticipating like a greater strain on EMS systems or EM departments where when these disasters do strikes and like, is there anything you see that would be beneficial in having like a protocol in place for this where, we're not gonna be short staffed with like emergency response, kind of like what we had with the fires. If you see that playing a role in ED or EMS at all.
Great question. I'm not sure exactly what you're asking, but for sure. I mean, as EMS agencies and preparedness get cut, um, we know they're gonna be under strain. And so yeah, FEMA for sure, right? I mean, that to me is insane with what's happening to think that that's a place we should cut. But it's these priority decisions are being made, and there's going to be consequences.
Yeah, the EMS system is there's lots of carbon footprint in that too. So we have people like Josh Gaither here is gonna got a grant to even just decarbonize some of the vehicles. So they're looking to create 2 Rivian trucks that are their go-to out and around in town. One of our other grads, Rom, is out. He was out in LA and works with LA Fire. And during the fires, actually had reached out to Rivian, and Rivian had provided some trucks for them at that time. And now he's going to start to work with them and come up with like an EMS platform. So going to help be in the design phase. So there's lots of like little, like this is again, doesn't have to go on a global scale or anything like that, but starting to decarbonize like little aspects of the system can make a difference. And, that's something he's passionate or interested in. So.
Very cool.
What other thoughts or questions do you guys have?
So you had a slide where you briefly touched on a little bit of how we're going to use AI in the future and moving forward to kind of streamlining different things. And so I was interested in your take on like what the balance between that and like the environmental impact of AI would have to be in the future.
There's no question. Yeah, AI is and I'm not an expert on AI itself, but it's no question we understand it to be an energy hog, and it's just the energy use. So this is society at large using artificial intelligence. I sort of separated that, and I thought, you know, a discrete AI look at a healthcare system's data can yield um, strategy and roadmaps that I think are something that no human could easily do. And if you almost think about it like a digital twin, right? So you create your healthcare system usage platform here, and then it's constantly uploading data from energy use or patient visits and things like that. Then you're able to kind of mitigate and turn knobs with more certainty about the outcomes. So um, I would say that to me um, is is incredibly valuable. Now, I don't actually know how much that particular effort would take energy use for AI. I suspect probably not as much as it would save. Um, but certainly we're going to see a gluttonous nation and world, proliferating AI, and it's going to be another energy sink. I personally think that there's if use to solve problems like this, it's a net positive. But of course, we're going to use AI for all sorts of stuff. Um, so I think that gets a little bit beyond a trade-off that I could speak to.
I think AI is here to stay, and it is an energy consumer. One of some of the good news, right? Though, if you look at like what was the energy sector, what was the percentage of renewables that hit the energy sector last year? 92% of new energy capacity. So if we continue to expand with good energy capacity going forward and focus that on renewables and kind of shift AI saying, okay, it's going to be here. Why don't we pair that with wind and solar and renewables to run said, and our partner that with storage? That's a totally different question, because if you're doing it in that space, then yes, in a sense, AI could proliferate for whatever if you're going to pair it. The worst part, right? The concern people have is that they're being paired with like methane peaker plants, right? That I'm going to put this peaker plant in to run AI and not use, renewable sources. But overall, we are moving towards, the new capacity coming online. And this is a big issue when we look at energy, right? We have tons of renewables in the queue, but we don't have good interconnection. If we got interconnected where they actually could access and be part of the grid, those large projects could start to power some of this. But it's a good question, but it's complicated. I agree. I think my take is AI is here. We just have to, how do we manage it? It's like with any new tech, how do we manage it and do it the right way? Nick asked a question here. How would you approach a CFO of a hospital system to convince them to implement a more carbon neutral strategy?
Yeah, great question. So it's sort of what I was saying, which is like you're a non-starter is going to be money, right? You've got to convince them that this is a cost savings in the long term, right? Everyone understands that capital outlays cost money in the short term. So what you basically do is like, I have looked at your data, ma'am or sir, and you can say, we have crunched it and we have um, data for you to, these paths are data driven for you to follow. And if you do these things, for instance, you do just outpatient, virtual visits for outpatients on Tuesday afternoons, your reimbursements will maintain or potentially even go up. Your carbon will drop by X. Your health equity and your patient accessibility will actually go up, assuming that people can get online and not have to get on the bus and things like that. And we don't think that's going to, dampen the long-term health anything. And it's a win-win. And they'll be like, you know, any smart C-suite person is gonna be like, okay, dude, show me the data. And you're like, here's your data. So you have to have data. And I think that's what I'm talking about. These playbooks by Healthcare Without Harm are so important, and they're written by geniuses, and they hold up, but they're not written for a specific healthcare system. And the ones that are, by Practice Green Health, they're very, very expensive for a system to come in and do a full audit, right? So we're thinking about the way things were done 10 years ago, right? A team of consultants coming in doing an audit, really expensive. But what we think with AI, or the idea is that it will be at scale and cheap and um, able to be updated. If you think about it in that terms of that, like that visual twin, digital twin paradigm, right? Where you can constantly see a snapshot of where you are. And then on your laptop, turn a knob. Like, all right, let's go outpatient on Tuesday after, or let's go virtual Tuesday afternoon outpatients. Beep. And then see how that all plays out. Incredibly valuable. And if you have the data to back it up, however imperfect, then you've got a fighting chance. CEOs just won't move that, which is why I mocked up that cheapy AI photo, which is the valley of death, right? They can't get them through the valley of death because they don't believe you, right? And fair enough, they're like, dude, I can't go into the red, right? I can't take my healthcare system into debt for 2 quarters and expect to have my job. So I'm not going to do anything. That's the most logical conclusion they have, right? So you've got to give them ammunition for them to go in front of their board and whoever they report to be like, we're doing it. I'm buying solar panels, and I'm confident that the third quarter we're going to we're going to see our return on investment and save money. That's kind of the difference from maybe where we were, 5 years ago.
Yeah. Well, I think, yeah, I mean, we talked a little bit about with sustainability yesterday. I mean, Jay, you and I may have to talk offline on something. We're trying to, there's three of us that are working on like a possible database, like a disrupting database, different than what NAM is doing right now, where we're basically it'd be a free access with almost, with articles, with climate smart healthcare, like off the shelf, ready to go, programs, like here's what you need to do. But to pair something like that with AI and to have that where you could just like put in your numbers, boom, 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 that would be really cool. Because I mean, we're working with Practice Green Health right now, and one of the issues is cost. And so it's hard when you say like, for our small campus, I said I need $5,100 for a 1 year consultant, and they never show up on site, but they're giving you the framework and all of that is great. But is there a way that we can do something where anyone, right, a small clinic, anyone could have access to this to be able to make that pitch to their CFO? And just to plug in some data, like I'll go look at the cost of gloves, I'll go look at the cost of IV tubing, and I'll plug all this in and my solar panels and my energy use, and I'll be able to come up with something very easy. So if you can make it accessible and like a plug and play, I think you can make a C-suite a lot more convinced faster. So
Yeah.
cool. Other thoughts or questions for Jay? Anyone interested in going to that disaster train thing? I know we were talking about the disaster stuff earlier and preparedness. Would that be kind of wild to go to? Yeah, maybe something you could try to like get your residency directors to like, instead of going to a conference, to do something like that. It'd be something unique. I think could be kind of um, a cool trip for each of you.
Is this like this principle of like kind of climate medicine or environmental medicine, like how and what like is it being taught at the residency level? Is it like starting to be incorporated more and more, or is that something that you think that like we should try to champion for, or is it just like specialty dependent? Like I assume REM program here with like Dr. Drummond probably gets some of it, but I like what level is this being disseminated?
It's a great question. It's all over the place. A lot of the effort has been, you can't get widespread change unless you change sort of the core competencies, and that really happens with like board questions, right? So if you can get a couple of board questions to change and represent, then everyone's going to have to address it. It really is, some people teach it because they think it's important. Others you can't get on their radar, and it's almost personality dependent. So I would say change absolutely comes from students, and then of course residents in residency programs. That if you want it, they will have to respond. You have more power than you think. I mean, certainly collectively. That's how our med school changed. We got students to frankly just ask for it. Um, it's frustratingly patchwork, though, across specialties and across training programs and even across med school curricula. The AAMC has tried to do some stuff, so there's been best practices, but again, med school curricula, it's so crowded. Um, we've had the best success. What I think, Brian, you're doing is an elective, right? So you guys have time off and you choose to do this. Um, but getting it into curricula that is mandated, particularly those first and second years, is really difficult. We've had some success here, but success is it's hour by hour that they give you. It's not like, hey, run a course. It's like, well, we can give you an hour in physiology, and we're like, okay, we'll take it. I'm gonna probably
Jay,
have to split at the bottom of the hour. Sorry, but yeah.
have you guys been able to, like some of the work that you've done, have you worked or tried to reach out to like the ACGME and trying to change even some of the wording for their, like for residency curriculums? They'll have like society, people, environment or climate, right? To add or subtract some of those words. What are have your efforts been on that, and success or not success?
Yeah, I've people have done it. I have not personally done it. I think Stefan was working on that actually a little bit. It's hard. It's hard to do. And yeah, it's worthy. I'm also kind of skeptical. I'm a bit different in the sense that I'm like, we just need to go build it as opposed to trying to like build two questions to sneak in there. But everything, you know this, like all of us pushing in every direction accumulates. So that so it's important. But yeah, I can't speak specifically about what's been done.
What did you create at Colorado? You said your med students brought something up. What do you do for the students there?
We created we have a fourth year elective, which we've had for years, a 2 week. And then now we have, and we actually have one of our, Beth Gillespie, she's one of our internists who's running it, is now embedded a climate curriculum in the longitudinal first and second years. So, different lectures. And that's probably, I don't know exactly how many hours it is because it's always changing, 8 to 20 hours over that 2 year period.